Welcome to the Behind the Drapes podcast. I'm your host, Kenny. In today's episode, we're going to be talking to Dr. Paula Caramez about her path that got her to where she is today. Paula was a part of my residency program, and she was the type of resident who, when she'd see you across the room, she would shout your name, come over to you, and check up on you and make sure you're doing well. She also has a very unique story that got her to the place where she is today. She first started her medical career in Brazil, graduating from the Sao Paulo University College of Medicine in 2002. After completing medical school, she then finished her internal medicine residency and went on to complete a fellowship in pulmonary critical care. In 2012, she moved to the United States, where she continued her medical career and started some fellowships in research, both at Harvard University as well as Northwestern University. In 2008, she matched in anesthesiology at Rhode Island Hospital, Brown University. Last year, she graduated from our residency program and stayed on as staff as an attending. Paula is an awesome person to work with, and I can't wait to get into her life story and how she got to this point in her career. Without further ado, let's get into it.
Yeah, are you recording now?
Mm-hmm. We're live. So welcome,
Funny.
Paula.
Thank you. Thank you very much. I was a little bit shy with all these introductions.
Well, I know you're not too shy in person, so hopefully as we keep talking, we'll bring out
surprise you.
Your natural personality. So why don't we jump right into it? Well, let's talk about what your medical career was like in Brazil and kind of those first few years when you first started working in pulmonary and critical care.
Actually, it was amazing, Brazil. I had like a lot of fun during my residence over there as well as I had over here. So a lot of teamwork as well. So I was originally from Rio de Janeiro. So when I went to São Paulo to do my training, it was very difficult because I was away from my family. It's a completely different environment, but actually I was very welcome. So I had a lot of good time and a good training as well. I did my resident at the same time with my PhD. So that's when I learned a little bit to do research. It was very intense, but we never complained about work. It was much harder in terms of hours than our residents here. So back then they didn't have this time of regulation hours. So nowadays it's different, but we did work like long hours. So it was unbelievable.
How many hours?
Even imagine.
What would you say on average?
I don't even remember, but it's at least 80 hours a week. Mm-hmm. Would be like 80 to 100. So when I see people here complain of 55, I said they have no idea what is working about it. And we didn't have this like post-late, post-call. Was pretty intense, but nobody complained. We were actually very happy. Everybody playing around. We used to go out. It was very good. It was a learning with a good environment.
Awesome. I actually didn't know that you got your PhD. So what did you do? What did you get your PhD in, or what was your sort of final project that you had to do?
Actually, it's a good question. So when you are doing your critical care part, they actually, it's like here, they introduce you a research. So they tell you to choose which part of the pulmonary and critical care you are more into it. So I did like patients with asthma and COPD. So there are different attendings which are more focused in each different area. So I basically got one attending who was more focused in mechanical ventilation patients with COPD and asthma. So he actually became my mentor. So you start your process of developing some kind of paper and research during your third year of residency. And then when you go to the critical care part, when you really develop your clinical material, it's very intense because you do the training plus the research. So basically I did my PhD was in patients with COPD and asthma under mechanical ventilation. So I collected the data during my third year of fellowship.
Got it. And were you sort of focusing on asthma and COPD patients as an outpatient as well, like in the clinic setting? Or was it only just ICU?
No, what patients were coming to the ICU, and basically they had and back then they had 10 different ICUs, one for neuro, another one for cardiac, another one for pediatric, orthopedic. But when the patients had any kind of a problem like asthma, COPD, they did call us to manage the ventilation. So we would go to different ICU. So when I developed my PhD, basically I got to have one bed reserved for those patients. So I would transfer those patients to the pulmonary critical care ICU, and we would be managed because we had a protocol to develop. So in order to keep under control, we would transfer the patient to our ICU, and I was the fellow that they would contact. Sometimes I would go to different ICUs and I would manage that as well. But that would fit the criteria to be part of our study. We would change a transfer to us.
And was your protocol like all vent management, like all settings that you would do with a vent, or was it also like steroids and
Yes.
like inhalational medications?
No. We developed a new way how to ventilate COPD asthma patients. And basically that became a little bit like a guideline. So in 1970, there was one way, which is a theory they call the waterfall theory, how to weaning these patients from the ventilator. And we proved that it would apply not to all patients with asthma and COPD, some of those. So we basically developed a way how to ventilate those patients and how to wean them from the ventilator. So that was the reason that I came to Harvard. So I got accept a scholarship to come because of this protocol. So part of this, I was in Brazil, and also I continued the same study in Harvard when I came here.
Okay, very cool. And how did you get linked up with Harvard? What was the connection, or was there a certain particular person that made the connection?
That is a very good question. So I was presenting, there was an oral presentation in one of American Thoracic Society. And basically, in a nutshell, my protocol was there was this theory that I told you, the waterfall. And my protocol showed that theory didn't apply to all the patients. So when I did, but that what was like basically everybody was believing. So when I did present that paper, people were like almost throwing eggs on me. So, but then it was so back in the end of the room was a big room with a lot of people. One guy, he lifted the hand and he said, "No, I want to talk to her. I want to ask questions to her." And I had no clue who was him. And then he was asking a lot of questions. And at the end of the day, he says, "Oh, congratulations. He was the one who developed the theory of the waterfall."
Wow.
And also he was one of the mechanical ventilation. And there was another physician, Martin Tobin, which is very famous. He's an anesthesiologist and he studied this. He was there and basically he advocated. So people became very interesting. And then he went to Brazil to follow our protocol, and he was asking questions, and he basically went to there to see it close, and he became a part of this project. And back then there were 10 people around the world who were studying asthma COPD. So one of these persons was Bob Kasmarek, who unfortunately is no longer among us. He passed away last year. He was from Mass General. So then he invited me to come over and to do my postdoc over there.
Okay, very cool. And what year was this? 2012 or?
I don't even remember, because the first time that I came in 2002. I was back and forth because I was still, I came in 2002 and then I went back to Brazil. I was like doing both things, but then I moved there. I was doing my postdoc in Boston like 2007. And but I did stay many years over there, totally 5 or 6 years. And but sometimes I was going back to Brazil and then I was coming because of visa issue as well. And but we did develop a lot of papers together along like 10 years.
Wow. So you had sort of an international relationship with these people.
Yes.
For a few years. Yeah. Awesome.
Yeah, we did meet a few times along the year in some congress, and sometimes I was coming to us, we were going to Brazil, so a lot of different ways. And not only me, but there were other like critical care fellows, and from Brazil, University of São Paulo, we developed kind of a partnership who are also coming here.
Mm-hmm. As you were sort of going through this process, did you always see yourself ending up in America or like in Boston practicing medicine?
No, actually, no, that was not my plan. I had an amazing life in Brazil. I had an amazing job. When I finished my residence, I was, University of São Paulo is a state university. So you have
Okay.
to go through a process to do a test. So I actually went through all that process. I became part of the team, like I was an attending. And then when I came here, it's supposed to be some kind of a temporary job. But then I met my husband, and there's a whole story. And my life pathway changed, and I decided to stay longer. I was never planning to do residency here. I was never planning to go through all those steps and process that I have gone through.
Okay. So I guess it sounds like you met your husband and then you started going through the process. What were some of the major milestones of ultimately getting a residency here, being someone from Brazil, and having to find a job here? Can you talk a little bit sort of about the visa or the application process for you?
There are three steps here. So first, visa. So then when I came to Boston, I had a student visa. They sponsor for me. And that originally was a 3 years process. So by the end of the 3 years, I was told by my boss in Boston that could be extended for 5 years. So it would be totally 5 years. So but then I got married, and my husband was in the process of a green card. So we got green card, we became a citizen. So that was a little bit easier for me. A lot of people don't have this opportunity, because if you have a green card, improves a lot of your chance, because you don't have to be looking for a programmer which is going to sponsor your visa. So it's a little bit complicated. I don't know details because, as I said, I didn't go through this process, but I know that if you apply for one visa, then after you change, you have to go to an underserviced area. And actually, Providence is one of the underserviced areas that you have to stay in order to switch from visa to green card. It's a little bit complicated. What I would advise for someone who is looking to it, to look at the current law, because they keep changing, and also each person is completely different from another. So each situation, you have many different ways to do so. So that was one part that, of course, in the beginning, when I was, when I had a visa to change to the process to green card, we had some issues because, as I said, this transition is not very easy, but you can manage it. Okay, so that was one part of the question. So, as I said, I was not planning to do residency, but when I was in Boston, the department that I was in was the anesthesiology. So, and I learned something here. So in Brazil, at the pulmonary and critical care, who manage the ICU, who does the ventilation, anesthesiologists, they are basically in the OR doing anesthesia. So never crossed to my mind to do anesthesia until I came here. So then I learned over here, also in Europe, I did spend some time in Italy, the anesthesiologist has a big role in the critical care. And most of the critical care are even anesthesiology. So I became fascinated because the departure from pulmonary and critical care that I like the most are exactly this critical care part. So I said, oh my God, this is much better because I could be doing all those critical intubation, ventilation, and anesthesia became a very interesting field for me. And so when I learned that I have to apply again in order to have the license, and I said, why not to do a different skills, learning a new specialty, and then it's going to be much more interesting because I'm going to learn from scratch, consider that I have to start over.
What was the most intimidating part of that? Of basically what you just described, having to go back into residency while also changing specialties, even though there's some overlap. Can you identify like maybe one of the biggest intimidators from that?
No, I think changing field, no. Because as I said, I became complete. I am nowadays that I finished the anesthesia residency. I'm going to tell you, I like anesthesia better than pulmonary. I absolutely love. I think you met me along this year. I was super happy doing the residency because I was like every day fascinated about what I was discovering and learning. And I think the hardest part was, first of all, going back to study for step one, two, all those, and some programs, they don't accept if you have more than 5 years of graduated. They don't even accept your application. So, and I have to learn how to perform as a physician in a completely different environment, completely different language. Now you can see from my accent. So, and then I have it. So I was training in a way completely different. So we have different culture, different values. So I have to learn like a medical student. That was the struggle part of for me. And I was studying at the same time that I was working. And then you have another thing is the way that you guys are training here to do tests like standardized tests that we were not training in Brazil. So it was a very complex process. That I think was the hardest part for me to fit in this process.
Yeah, that makes sense. Did you have to take standardized testing in Brazil, or like what kind of tests were you taking? Were they more like open response test or OSCE style tests?
You do, when you apply for medical school, you do a national standardized test. So that is one, but they keep changing now. They're including now your score from high school that they didn't do back when I applied. So they are changing now. So you do this, and you do the boards as well, the pulmonary, critical care, those kind of things. And at the end, depending on the specialty, at the end of each year, you do. But here you test all the time. We have an in-training test, you have the board, the basic, the advanced, for example, for anesthesia. So it was kind of different. We didn't have, like in the years of the medical school, you have the test in the medical school, but you don't have this common test like USMLE 1, 2, and 3.
Mm-hmm.
So, and the way that I stressed is different also. The way they teach nowadays is also different in Brazil, but the way they teach in Brazil, the way they teach over here, everything was different. The way they present a case. And so that is a different story. When you start, I did the test, but then when you start practicing, you also have to learn how to present your thoughts. So it's very complicated. If you are training one way, in one language, one culture with different values, and then you come to perform in another one, it's complicated. Some people, they judge your medical knowledge based on the way that you present, the way that we speak. And sometimes you have just to learn how to do the ways it has been done here. And along this process, you suffer. It's not easy, but you can do it.
This is an intermission. We're about halfway through the episode. Feel free to pause it, give yourself a mental break, and come back to it later. If your commute's not over or you're really into the episode, feel free to keep pushing forward. But if you need to take a break here and reset yourself, go ahead, put the podcast down, and come back to it at a later time. However, it does seem like most of the guests save their best for last, so you'll be sure to want to check out the rest of the podcast and the end of the episode to see what everyone has to say. One thing I wanted to ask you about was when you joined Brown's residency class, you were sort of at a different stage than the average person who's coming out of medical school. And could you just elaborate on kind of the role that you took in your residency class or the residency program? And if you think it affected kind of how you acted amongst your colleagues or your peers at all, being in or having already practiced medicine and also being in a bit of a different life situation as some of your co-residents?
And that is a very interesting question as well. So there were two steps. The first was my first year, the internal medicine, the internship. So that was very hard because that moment was when I have to learn how to perform as a physician here. I have to learn even to take the history from a patient, do a physical exam, assessment plan, completely different. So, and the hours, they were different rotations. So, and I had a lot of friends. I had an amazing year, but we were working a lot. So I have to work a lot, learn this process, and I have a family. I didn't even live in Providence, where most of the residents were living. They were hanging out, going out. Basically, I was going there, working, and when I had a free time, I was back with my family. And so that was kind of, but a lot of people also had children. I was not the only one. Even though they were younger, a lot of people have family. They didn't do this kind of lifestyle like before. But, and the difficult part for me was the hardest, was the first year to learn how to perform as a physician over here. Even though I was at Mass General, but was in a different setting. So I have to learn how to present a case for my attending, how to do the assessment plan, do everything exactly the way it's been done here. So that was harder. So when I came to anesthesia, it was much better. First, because the hours are unbelievable better. It was a small group of people. We had like the same setting. But that was very interesting because our first day that we met, we were all put, it was before COVID, thanks God, that time we could be in a small room. We all were in a small room together, first week of orientation, waiting for Dr. De Oliveira, our chair, to come to give his speech. So I get there late, I was late, and then everybody was sitting on the phone. Nobody was talking to each other. And I said, And then I look at people's faces, I said, oh my God, this looks like a kindergarten. What am I doing here? And then I look at each face and I said, guys, listen, we are going to spend 3 years together. Don't you think this is an opportunity for us to meet each other, to talk instead of... but I knew one of them because we interviewed together. Then we started talking. It was a little bit more relaxed because I was kind of stressed. Dr. De Oliveira is coming, making his speech. What is his expectation? And then he comes and he says, I expect one thing of you guys. Is the most important.
Show up on time.
Probably be nice.
Oh.
No, he said, be nice. And I said, well, I'm here waiting for this chair to tell us something. How is his expectation for the residents? And he said, I'm already nice. What he's talking about? Be nice, be kind, be polite. And I said, you probably had the same advice when you came in. And then everybody was looking at it, but that kind of, I said, okay. And then he said, I don't care if you, it's not that I don't care, but it's not the most important if you put an A line, a central line, but it's very important that you have a teamwork. You are nice to each other, you help each other, then you are nice. He kept saying that to be honest, now that I've gone through my whole training, and I could understand the importance of that advice. And going back to that day, we left that room and then we went to a locker room and I could not open my locker. I had no experience with locker. And then I asked one of my colleagues, can you please help me with this locker? She says, if you would have gone to medical school, college here, you would know how to deal with the locker. And she comes, she teaches me. And then we start all laughing a lot about this. So I get home, my daughter says, Mom, I got late today. I lost the bus because I didn't know how to open the locker. And I said, oh my God, I did have the same situation of my daughter.
That's amazing.
Said, okay, good. So then along the year, we started helping each other. My class was amazing. As a matter of fact, Danny Bui, who is now attending with me, he was doing cardiac in front before me. And when I started, and I was asking him how to set up the room, and he says, I will come over to help you. He came 5 a.m. to help me to set up my room. And I said, I can't believe it. Same thing, Shirini, she also was on call one night, and she woke up earlier just to set up the room for me. So those kind of situations didn't play a role if they are younger, older. We were like a teamwork, classmates helping each other. So that was the advice that a doctor, and then they became a chief residents, Shirin and Dani, and they are very good friends of mine. And along the way, we were like help. I had many examples with many other classmates. I just gave you this example now. So at the end of the residence, and I said, wow, do you know what I learned about being nice, be kind, and be polite? If you are struggling, it's much easier someone come to help you if you are nice. If you're not nice, and that plays safety for your patient, because everybody's going to help you to make your care better and overall safe for the patient. So you get together, you make a team work, but overall you are providing a better care. So I understand now that advice, and I keep telling the same to my residents. So going back to your answer, I think it doesn't make difference if you're older or younger, but it makes difference if you are nicer or not.
That was an amazing answer. That was a beautiful story with you and Ella both having troubles with the locks, and also that's amazing. And also incredible examples of two really great co-residents. And like you said, you had a bunch of great co-residents in your class who all looked out for each other. And I think anesthesia kind of breeds that sort of culture where you sort of rely on each other, especially in hectic situations like traumas, to come in and help each other. So I think you hit on a lot of awesome points there.
Totally agree.
My next question is, why did you decide to stay at Brown as an attending, and how are you feeling about it now, about a month or two into your job?
That is an easy one. First of all, I think that was the best decision that I made. So I love my job. I love the people that I work with. And there are, before I thought there was advantage and disadvantage to be in a place where you train, but so far I have seen only good things about it. I think, first of all, it's much better. You are in an environment that you already know. You know the surgeons, you know your colleagues, you know who to ask help, and you know the electronic medical record, you know the system. I think you take out of the road this kind of stress when you go to a new place. When you go to a new place, you don't know exactly who can ask help. Even though you should ask, but it's more, you feel more comfortable when you are in an environment that you were training. And I think so far I have got only good things to talk about this. And another thing is, I totally believe in our training. I think we were very well trained, and I want to stay in a place that I trust. And we had a variety of cases. The fact that we don't have a fellowship, we do so many different cases, and we had amazing experience. So I was wanting to be practicing in a place that I was training, because I totally believe in this training. So that was one of, also would be for personal reasons, would be easier for me here. So it was a combination of reasons. But the main point is, I think it's very good to be practicing in the place that you were training. So, and have said that, how I am, so when you finish, actually, your learning doesn't, when you finish your training, actually, that when you start your learning, because it's very exhausting. You do a training, at the same time you study for board, you study for ITE, and it's a steep learning, especially in the first few years. But now you kind of have a comfortable, okay, now I'm going to practice, I'm going to try what I have learned. And it's good that I have the comfortable, that I have a backup to ask for help, but I want to trust my gut. I want to trust my feeling. I want to try new way to provide anesthesia, but I also want to keep open mind for a new possibilities. Like today, I was working with you. So I took over your room. Your attendants gave to me the sign out. So I walked through the room with a plan in mind. So I got there and I said, okay, Kenny, what is your plan? So your plan was different, the one that I had, but I actually like it. And I said, okay, let's do it. And when I went to give you lunch, I absolutely loved to wake up the patient. You started Caramez infusion. I was planning just to do regional for her pain problem. And I absolutely love this. So I think this open mind, it's very good, because anesthesia, that is like a cake. I keep saying there are different ways to do the cake. Some people like this cake better, other people like, but the point is, if you are being safe, if you are providing a good care, doesn't matter if your choice it's different from mine. If it's safe, if it's good for the patient, let's do it. So that is one of the the point that I have been tailoring my mind, like teaching with an open mind, respecting people's opinions in a way that I'm also learning how to provide anesthesia. So that is one of the big point now from my learning process as a new attending. So the second question was, what was the second question? I was about to write, but I didn't.
You kind of answered that with sort of like why you're happy to be here. But I can get it, this sort of leads into the next question, and our last question, which was if you had to leave the listener with sort of a learning pearl, what's either one thing that you like to teach your residents now on a regular basis that you kind of have this like consistent lecture or topic that you talk about? Or is there something that you've learned in the past couple months that was like an interesting case or a case that really sticks with you that you think has like a really good learning pearl from it?
Yeah, so what I have been doing is, first, I'm fascinated because when I was in Brazil, I did teach the fellows, the critical care. We did teach a lot to the intern. So, but during my whole process of the residency here, I kind of was focused more in learning than teaching, even though we had some students coming over. So now, as an attendant, there is this fascinating challenge is to learn how to teach. So, and first of all, you have to learn to give feedback without frustrating, but also learn different personality with different skills. So I was trying to tell them that it's not important if they do arterial line, central line well or not, but it's important for them to learn that first of all, they have to be safe for the patient, and that they are always in the process of learning. They are here to improve. Everybody makes mistake, but you cannot put your mistake, push you down, that you don't progress. So that is one point. Another point is, I try in terms of teaching, I don't teach only one. In the beginning, I did ask everybody how they monitor, how they know about monitor, because I thought that was the basic, most important. Because if my resident is in the room and if he calls me, I want to hear at least, oh, the entitled CO2 is going up and down. Why? So at least basic stuff I did do with all of them. Also to have a sense where they were. So now I do based on the day, which case they are doing, and then something, because I think it's more interesting for them to learn practice based on the clinical case of the day. And I ask, of course, questions if there are something there, but I always ask, what complications can we encounter? What is important for you to see in pre-op? What about the intra-op? What do you do if the blood pressure goes up, goes down? We always have those pink medications, but also complications. What can you find in PECU? What can you find in 2 days later? Like another day I had a thyroid. I asked the resident, what happened intra-op? What happened when you just extubate? Impact or 2 days later? Those kind of things that we do. I try to make something more, and I don't tell them ahead what I'm going to, because I don't bring this stress. Oh, I have to study for my attending tomorrow. We have already so many lectures. We have a lot of keywords. I think the teaching part from our program is also phenomenal. They have a lot of academic, a lot of keywords, and I'm there just to help them to provide the care for that patient. So I want to show them what things they should be important, high yield for them to learn. That's the way that I kind of doing. But in a nutshell, I'm more learning also how to provide teaching without frustrating them. But the most important point, I'll tell you, for me, it has been to find the limit between push them to do something or take over. Because you don't want to, you have to be safe for the patient. But if you take over, you also take the opportunity for the resident to learn. But when is the limit that is safe for the patient? And you are providing education, but it's safe for the patient. That is the learning process. Another day I was frustrated. I said, I think I took over the intubation too early. But then I said, oh, okay, I still have some time to go. And I'm going to learn with time. So that is my biggest challenge now, learning this limit between pushing and takeover.
Yeah, I totally see that. And I think even like when you work with different attendings, you notice that different people have different thresholds. And I think it's just something you probably learn over time and gather over time as you just encounter these scenarios more and more throughout your practice.
Yeah, I agree. And also when I work with like a CA3 like you, it's much easier because I know your personality, I know your training, I know your level. But when I'm work with CA1, I have to learn their personality, I have to learn their knowledge, skills. Sometimes I work like some of them I work like 3-4 days, and then at the end of the 3-4 days, I kind of have a picture how I can push, how I can hold situations like that. But when it's
Mhm.
completely new, it's a challenge, but it's fun. It's been actually a journey.
That's awesome. That's awesome. Well, I'm glad to hear everything's been going well and these past few months have been treating you well. But this was awesome. I had an awesome time chatting with you.
Ah, so do I. Thank you for having me. I think it's
Yeah,
very good, this program, the keywords that you are developing. I think I have seen a lot of work that you have done over there, and I absolutely enjoy. I was talking to you today about the pacemaker. It was so interesting because we could talk about something that you wrote over there. And good luck. And I think you're going to love critical care. You're going to be doing great over there. And I had the opportunity to work with you as an attendant like few times, and good luck.
thank you, Paula. Thank you so much for helping me with this project.
Oh, thank you. It was a pleasure to be here. Thank you for having me.
Of course. Thanks for listening to Behind the Drapes. If you like what you hear, check out the podcast homepage where you can check out other episodes that have been released, and make sure you hit the subscribe button so you get all the new episodes to your homepage as they drop. Also, if you like the educational stuff, check out the Instagram page and the TikTok page, Keywords by Kenny, and also the website keywordsxkenny.com to see some more full in-depth explanations for keyword topics.